Welcome everyone to the Friday AIHM Wellness webinar. We're just thrilled to have everyone here today. We've got a great crowd, and I'm very honored to be presenting the guest speaker today, Drs. David Katz and Jaclyn Chasse-Smeaton. They're going to be talking with us about transforming nutrition, and I really want to thank our sponsor for this webinar, Emerson Ecologics and Elevate. We're really thrilled to have them as a partner and to be working with us during this year and previous years as well. So thank you, Emerson. So while people are coming into the webinar, I'll just, for those of you who are joining us for the first time, welcome to the integrative health community. The Academy of Integrative Health and Medicine is a global interprofessional integrative health association working to transform healthcare, body, mind, spirit, community, and planet. And we came really from two organizations and now a third, which we're very excited about our recent merger. We started as the AIHMA, merged with the ABIHM, to form the Academy in 2014, and recently this year merged with the Academic Collaborative for Integrative Health. And so as we grow our integrative health community, we're just really excited to be able to deliver you all more information, education, and bring our integrative health community together. So if you haven't joined our YouTube channel, you can subscribe to youtube.com/AIHM Global, and you'll get access to all of our free videos every week if you're not able to make it right at noon Pacific time. So with that, I would love to introduce our special guest today. Dr. David Katz is a medical doctor and MPH. He is the founding director of Yale University, the Yale Griffin Prevention Research Center. He's the past president of the American College of Lifestyle Medicine, and he's published roughly 200 scientific articles and textbook chapters and 17 books on both preventative medicine and nutrition. And I just want to say that, Dr. Katz is really one of the pioneers in this field. I could go on for a whole day with his resume and what he's done to move forward preventive medicine in this country and globally. And so we're just so thrilled to have you today, Dr. Katz. Also joining us is Dr. Jaclyn Chasse-Smeaton, who's the Vice President of Medical Education for Emerson Ecologics. She served as President of the American Association of Naturopathic Physicians and the New Hampshire Association of Naturopathic Doctors. She served on the boards of the Integrative Healthcare Policy Consortium and the American Herbal Products Association. And again, thank you, Dr. Chasse-Smeaton and Emerson Ecologics and Elevate for making this webinar possible this week. So with that, I will pass it over to our presenters, and I'm really looking forward to the presentation today.
Wonderful. So thank you guys so much. I'll turn my video on here, and Dr. Katz, you can join as well. Thanks, Tabby, for such a warm introduction. Like she said, I'm Jaclyn Chasse-Smeaton with Emerson, and we're really honored to have Dr. Katz on our medical advisory board and also be in deep partnership with them with this amazing tool that I know you're going to be as wowed by as I was when I first heard about it, DietID. So truly, I think at the end of this hour, you're going to think how your practices could all be so much easier and your time with your patients more effective, and your patients will like you a heck of a lot more. So Dr. Katz, I'll let you take it from here.
All right, Jackie, and thanks to you and you, Tabby, for such kind words of intro. I hope my mom is attending the webinar. She'd love this. And, not listed among my credentials there is a long direct involvement in integrative medicine. And Tabby, I know you know this history, but definitely relevant to this audience, and a pleasure to join with you this afternoon. So I actually founded and directed an integrative medicine center at Griffin Hospital in 2000, ran it for 15 years. We focused on evidence-based integrative medicine, and we had a unique model. There are many approaches to integrative medicine, many of them involving integrating fields of knowledge within one person's brain. And, I think it's partly the fact that, I wasn't sure I could stuff much more in mine, that I thought, this may be a case where two heads are better than one. Rather than me pretending that I know what a naturopath knows, let me work with one who already knows it for sure. So we developed this team care model where every patient was seen jointly by someone trained in so-called conventional medicine and a naturopathic physician, and we did a dual evaluation. Most of our patients had hard to treat stuff. People that came to us were people who'd been everywhere, tried everything, and were still unhappy. So, people with syndromes, hard to treat conditions, the usual slings and arrows of outrageous misfortune with the modern medical system, they found their way to us. And we were often able to help because essentially what we did was look across the full spectrum of options, and we endeavored as a team to be agnostic to the source, whether it was conventional medicine or natural medicine. We took to saying over the years to our patients, we don't care all that much if the best treatment comes from a test tube or a tree leaf. We care whether it truly is the best treatment, safest, most effective, if there's relevant evidence, and ultimately if it works for you. That's the ultimate test in medicine. It's all about the N of one. And so for 15 years, we ran that model, and we ran a residency program as well for naturopathic physicians. And as many of you know, those are pretty rare. And we had the advantage of being situated in the Prevention Research Center, having direct access to Yale. And so we focused not just on the clinical model, which was quite innovative and which we presented back in the day at a symposium held by then the IOM and now the NAM. But we focused on the generation of evidence, the importance of evidence. So we published a number of papers, both about the model and specific research studies. And it's actually good timing because his birthday recently came and went for me to shout out a colleague and a dear friend taken from us way too soon, not by COVID, this was before the pandemic, but Ather Ali, whom many of you know. So Ather was a naturopathic physician and got his master's in public health at Yale, and was the first ever naturopath on the faculty at Yale, which is a stodgy old place. That's not a breakthrough in places that are reasonably progressive. Yale is not on that list. So, we were members of the academic consortium in integrative health and medicine, but the idea that there'd be a naturopath on the faculty was really, a singular achievement and a credit to Ather, who secured a K award. And I imagine many of you know him and know of his work. I miss him terribly. We worked closely together for many years. Ultimately, he came to co-direct that clinic. Tabby?
Yeah, so I love that you brought up Ather. He just was so important and such a beautiful human being. And I had the pleasure of actually working with him, with one of his students. At the time, I was running an integrative clinic in Nicaragua, and he was overseeing her research project at Yale. And truly, there are few people I've ever met that are like him. And he moved so many things forward, but just his person is what we all remember and truly do miss. So I just thank you for acknowledging him.
Thank you. I know we honor his memory. We're currently wrapping up the 4th edition of Nutrition in Clinical Practice, and had Ather still been with us, as he should be, he would have been one of my lead editors. And we're dedicating this edition to our patients who taught us so much, and to Ather. I really do miss him terribly. So thank you. I appreciate that. And I joke, those of you who knew Ather, and it's so hard for me even now, it's been a couple of years, to say it in past tense. But I joke, those of you who knew him know that he mumbled terribly. I mean, more often than not, you couldn't hear what he was saying. But he was always saying something important. And my joke is that, you could almost never quite hear him. I was always imploring him to speak up. He had important things to say. But his voice in my head, has never gone away. I hear it all the time. And anyway, I miss it. So, integrative medicine is near and dear to me. I think the basic notion that the needs of patients go on long after the results of RCTs run out is just fundamental to the practice of medicine. I think we are most valuable, most needed. We are most truly healers when it's not textbook obvious what to do. I mean, when it's just, yeah, this obvious you have this condition and this drug treats it and it's easy, see ya. Anybody could do that. Frankly, that can be fully automated. It's a perfect case for machines to take over. Most of medicine isn't there. Most of medicine is a little bit in the fog, in the gray zone. And wow, we tried the obvious stuff and it didn't work for you. Now what? And so I applaud what all of you do. And, I'm honored to have devoted a portion of my career to that. And again, honor the memory of Arthur, who taught me so much and who I miss very much. Jackie, I'll take the next slide, please. Thank you. So we're extremely proud of our partnership with Emerson and Wellevate. And we're going to talk about a fundamental advance in dietary assessment and all of its implications. But one of the important implications, you think about an online platform where you can secure supplements. I've long noted that we use the term nutrient supplements, and there is then a large gap in the discourse because the very word supplement implies that it be supplemental to something. We almost never talk about the something and the obvious something. Of course, now, again, I'm preaching to the choir to some extent. Usually I'm ranting at my conventionally trained colleagues who don't do any of this. You guys are much better. But the something, of course, is the nutrients people get from food. But even if you're sensitive to that issue, you probably don't have the data. So, when we think about nutrient supplements, if we're not going to guess, hey, you probably need this because most people do, if we're going to be more refined than that, more N of one than that, more personalized than that, we need to know, well, what nutrients are you getting from food? And we need a mechanism to get there from here. And this partnership honors that concept. So the idea that every clinician in this platform can empower every patient to do a comprehensive dietary assessment down to the level of nutrients, identify specific shortfall nutrients, and then obviously you're using nutraceuticals for purposes other than redressing shortfalls. You'll continue to do that. But you'll also be able to see at a glance on your dashboard, where is this particular patient deficient in nutrient intake levels from diet, which is an obvious place to supplement to remediate those gaps. You can also then coach to improve diet, but in the meantime, let's fix the gaps. That's the ideal application of nutrient supplements. And again, I fully appreciate that the use of supplements extends well beyond just filling gaps to nutraceutical application where, essentially they're exerting a pharmacotherapeutic effect. Do both. But I think we can do a much more elegant, tailored approach to supplementation. And by the way, that's long been a goal and an elusive one for that space. And I trust Jackie would agree. And, I happen to know that some of the big nutrient supplement manufacturers have been wrestling for years with issues like nutrigenomics. Is that what we need? Do we need to profile people's SNPs in order to decide what nutrients we should be supplementing? And, with rare exception, obviously, methylated folate is a clear example where knowing something about genetics is quite helpful. There are others. But for the most part, the answer is no. The science really isn't there yet. What we do know, though, is the level of nutrient intake that people ought to achieve. And if they're not getting there with diet, it's a perfect argument for supplementation. So this partnership really is an expression of that particular application. We're delighted. We also think that this partnership can evolve to do a whole lot more than that. And as I described this tool for you, I hope you'll join us in thinking about all of the potential here. Next slide, please, Jackie. So one of the motivations for me in my entire career, which has taken this, what I suppose might be considered a bizarre turn. So, as an academic physician for 30 years, I was at Yale all that time. I directed the Prevention Research Center for 21 years after establishing it in 1998. And now all of a sudden I've left academia and gone into the private sector. I've gone into the private sector because I want to win. I've long thought that the only way for me to go gentle into that good night, and I'm in no rush. We're talking about the fullness of time. as if I make a difference. And, when I started my efforts better part of 30 years ago, they were directed at reducing the burden of preventable chronic disease, reducing the burden of hyperendemic obesity. Um, but alas, things have mostly gotten worse since then. And we have more obesity, we have more chronic disease, and diet is the leading driver of that. So it's now well recognized in the literature that the single leading predictor variable of premature death, and by the way, this is arguably true even during the pandemic, and happy to answer questions about diet, immunity, and the pandemic after the fact. But even during COVID, where we've had 480,000 deaths, is it now, in the U.S. in over a year, diet is still worse. Junky diet is responsible for 500,000 premature deaths every year. And of course, it feeds into the 655,000 deaths from cardiovascular disease, and on it goes. And there is no fix for this other than making diet better. The big food companies, and in particular the beverage companies, would like to tell people that, if you exercise enough, you can eat whatever you want. Well, that's not true for two reasons. I mean, first, if we're talking about calories and energy balance, it is so much easier to out-eat exercise than to outrun all this hyper-palatable food. So most people will fail in their energy balance endeavor. But obviously, the quality of the fuel is critical. Regardless of the quantity, you want a high-performance machine, you need to put in high-performance fuel, and the human body deserves no less. So massive implications of poor diet quality in this country. So if you're going to identify, I want to fix a thing. I'd love to be more ambitious and fix lots of things. I just don't expect to get that done. I'd like to be involved in fixing at least a thing. So when my time comes, I can go gentle and feel like I accomplished something. For me, that thing has always been diet. When I started, 1993, that was the year the seminal paper came out in JAMA from Bill Foege, Mike McGinnis, Actual Causes of Death in the United States. And back then, nearly 30 years ago, tobacco was the #1 cause of premature death, diet and physical activity close behind. Diet is now #1, the inarguable #1, partly because we're smoking a lot less, yay, partly because we're eating so horribly. That's what needs fixing. So this is a hugely important issue. Next slide, please, Jackie. And we have an expression from the world of business, which I have come to know over the past 5 years. I formerly didn't know much about the world of business. But I think it's equally germane to medicine. And there are lots of ways it's usually said, and there's debate about to whom it ought to be attributed. But the expression is, we manage what we measure. And we generally don't reliably manage what we don't reliably measure. And in business, they're talking about KPIs and SWOT analyses, and how is the business doing? What is our market focus, and all of that. In medicine, it's vital signs and biometrics. If it's important, we measure it. Imagine a world where we all agreed that blood pressure was really important to cardiovascular outcomes, to whether or not people were at risk of stroke, and on it goes. Super important. We all really care about it, but we never measure it. How disempowered we would be to manage it. It's a non-starter. So where are we in measuring the single most important predictor variable of all-cause premature mortality in the United States today, diet? Not in a very good place. These are your options. So, bottom left here, you can do calorie counters, but, counting calories is really not a comprehensive assessment of diet. So that could help you potentially get at energy balance issues. The methods for comprehensive assessment of diet range from just a free-flowing conversation, so we'll call that an interview, which is probably formalizing more than it deserves, but hey, let's talk about what you usually eat. And again, 30 years of patient care, I know how that goes. If you really want the details, you have to work at it for an hour. I've had it take longer because you'll get answers that are as much deception as disclosure. Oh, well, I have a salad for lunch. Okay, well, tell me about that salad. Well, half an hour later, you've gotten the details. It's a chef salad that has no lettuce in it, but a whole lot of, cold cuts and cheese. So I can't understand why my cholesterol's not improving. I eat salad every day. Devil's in the details. So those interviews, they're cumbersome. What we typically rely on if we're formalizing this would be 24-hour recall. And those are notoriously inaccurate. Tell me everything you ate yesterday. Inevitably, when you ask that question, yesterday turns out to be a singularly good day. Everybody happens to have been highly abstemious yesterday. And this is well reflected in the research literature on 24-hour recalls. If you do enough of them and aggregate them, they're reasonable. Better than that is a food frequency questionnaire, but a semi-quantitative food frequency questionnaire that asks you about everything you've eaten over the past 6 weeks to 6 months. Frankly, we can just do this now and all agree how horrible it is. And it's a great tool. Credit to those who've developed them. Gladys Block, Walter Willett. Okay, good tool in a sense, but how many times in the past 6 weeks have you had, say, pasta? And by the way, exactly what kind of pasta? And by the way, exactly how much pasta? And by the way, what did you put over the pasta each time for the past 6 months? And by the way, how much of that? And you get the idea. Now amplify that by every food you've had in the past 6 months and imagine how accurate even we could be, let alone the average layperson, the average patient who's struggling to, I have no idea. So, human beings are notoriously bad at recollecting detail, and that's exactly what we rely on to conduct dietary assessment. These are cumbersome, tedious, time-consuming, inaccurate, and frankly, pretty onerous. Some of you may know a good friend of mine at Stanford, Christopher Gardner, premier nutrition researcher, and we were at a conference together before the pandemic. And Christopher has actually been involved in this effort, as you'll see. And I asked him, tell me, brother, have you ever made it all the way through a food frequency questionnaire? Is this the sort of thing we really don't want to disclose in public? He said, absolutely not. Never, and neither have I. You're halfway through, your eyeballs explode and you're done. It's just horrible. So this is the state of the art. And this has really frustrated the hell out of me because, I've done the academic triathlon most of my career. So teaching, patient care, research, this has been rate limiting in all three. Patient care, I've often wanted to know what my patients were eating. We didn't have access to that information without a great deal of muss and fuss. Research at the Prevention Research Center, many times over the years, we actually identified change in overall diet quality as our primary outcome measure, and routinely failed to reach our sample size requirements because of the measure that we were trying to get. People, nothing we could do that our IRB would accept would get enough people to fill out food frequency questionnaires. So on a number of occasions, we had to adopt a secondary measure as our primary measure and explain that in our papers because we simply couldn't get enough people to complete semi-quantitative FFQs. And then in teaching, everything we want to build our arguments on about dietary intake in the United States depends on what we know about dietary intake in the United States. And the whole damn thing is resting on a very flimsy pyramid or foundation. The NHANES trial is based on 24-hour recalls and a relatively small sample that represents the whole. This is the state of the art. It's as if, we've got nails to pound and all we've got to do the job with is rocks. Somebody needed to invent a hammer. Next slide, please, Jackie. And it came to me. And it could have been anybody. And, as you'll see, this is incredibly simple, really. In fact, so simple that when it came to me, and by the way, shout out to all of my fellow exercise enthusiasts. I was on an elliptical machine working out when this came to me. And it literally, it was like origami in reverse the day this happened. It was a day in February in 2016. My son knows the exact date because I hopped off the elliptical when I was done all sweaty and said, Gabe, I think this is a day that's going to change our lives. But basically, it dawned on me. I was thinking about things like Malcolm Gladwell's Blink. I was thinking about the terrific coffee table book, Hungry Planet, What the World Eats. If you guys don't have that on your coffee table, definitely recommend it. It's an ethnographic exploration of the world's dietary patterns. And for every image in the book is a family from a different culture and their food for a week. And it's incredible how much you can discern about variations in dietary pattern, diet quality with just a quick look at that picture. And they're lovely because it's the food and the family in those cases. And then the other inspiration, and I can't recall that particular February day in 2016 if I had recently been to see the eye doctor to make sure I had the right version of these, but maybe I had. And when you go to that ophthalmologic visit, you inevitably use a phoropter, which is this sophisticated optic device to the left, producing these simplistic images to the right. And the question to you is, which balloons are in focus, A or B? And obviously, in this instance, you would answer B, but you're not done. You then get 2 more pictures, and the question would be, how about now? And then 2 more pictures, how about now? And you know how the game goes. Ultimately, you reach the point where your vision in diopters is all sorted out. And if you need a corrective lens, they know exactly what your prescription needs to be. And the epiphany I had that day on the elliptical machine with origami and reverse in my mind was, can't we do this for diet? Can't we reverse engineer the whole damn thing? We're asking people to try to assemble a representation of their overall diet, one badly remembered food at a time. What if we jumped to the end game and said, we'll build representative prototypes of real world diets, turn them into images, and we'll show them to people and say, which looks more like stuff you eat, A or B? And instead of relying on recollection, which is a native human liability, we'll rely on pattern recognition, which is a great human strength. Discussed in all the anthropology books, including, for example, Sapiens, which some of you may have read recently. Next slide, please, Jackie. So this is what we do. DietID is predicated on a method called diet quality photo navigation. And effectively, what our app does is learns a little bit about you. Do you eat meat? Yes or no? Do you eat grains? Yes or no? So we can show you the relevant portion of our comprehensive diet map. And by diet map, I pretty much literally mean that. So we have a team that does culinary cartography, and they've populated a grid with 2 axes. On the x-axis, we have diet type, operationally defined, which ranges from paleo, low-carb, keto, in what we call the West, because it's to the left, and vegan and variations on the theme of vegan, whole food, plant-based, all the way to the east or right, and everything in between. And then on the y-axis, we have diet quality, objectively measured using the Healthy Eating Index 2015, and we stratify all the diets into 10 tiers of quality, and each of those is an image. So it's a big map, and we need to know which part of the map to show you before we start asking the this versus that question and playing the game. So we do a couple of screener questions. They take about 5 seconds, and then the game is afoot. And this is the game. 2 images, which looks more like stuff you eat. And I'm quite confident everybody attending this webinar is going to pick B, and then we'd go from there. So you start at, and by the way, the phoropter game is much the same. In the beginning, one picture is glaringly out of focus and one is quite in focus. As you move through it, they get closer and closer together. I always find that the final selection is a toss-up. I can't tell whether A or B is more in focus because they're both pretty darn good. We do the same. So, we recognize that at first it should be an easy choice. One diet's really poor, one diet's really good. And then when we get to the end, they're very close together. Next slide, please, Jackie. And one of the things we're really proud of, we had DietID sponsored a webinar earlier this week, and we had 3 experts on ethnic diets: Tamara Melton, Sarah Bersenat from Old Ways, and Sylvia Klinger, I believe it is. And we talked about this being a really timely issue with extremely important implications. This was in the New York Times recently, by the way. The idea that the Academy of Nutrition and Dietetics is maybe a little too white bread, that, we recognize people have lots of different ethnic diets, but when it's time to eat well, let's just talk about DASH. When it's time to prevent diabetes, let's talk about the DPP and it's one size fits all. That's nonsense. So what we've recognized, we're out ahead of this issue because, again, we're objectively measuring diet quality for all these different kinds of diets. We can do that for Indian diets and Chinese diets and Mexican diets and other Latin diets in America, and we're doing that. So we started out with the basic array of diets that represented something like 95% of the American population, and we're now moving out to more ethnic diets, more restrictive diets, more therapeutic diets, so that we can capture almost everybody, so that whatever it is you're eating, you can find yourself in our map. And the Mexican diet is one of our most recent additions. I'm not wildly enthusiastic about the keto diet. You can ask me why, but the simple fact is people are doing it, so it needs to be there for the onboarding process. We're adding 2 versions of a South Asian or Indian diet, both a mixed diet and vegetarian, and many more to follow. Important issue, timely issue, germane to all of nutritional epidemiology, but again, we're kind of out ahead of it and really proud of this. Shout out to my team. Next slide, please, Jackie. And the basic innovation here then is this whole new approach. First fundamental advance in dietary assessment methods in our lifetimes. The FFQ was the last big advance, and it's been around for many decades. There's been lots of money up for grabs to develop new ways to assess diet from the NIH, from the Gates Foundation, and for whatever reason, it didn't happen. So this is the first fundamentally new method in a very long time. But resting then on that foundation, we can do a whole lot of other super cool stuff. If we can, keep in mind, for example, that if you want to draw a line, you need 2 points. And if you want to draw a line from where your diet is to where you'd like it to be, you need to know both. It hasn't been easy to do. It's really easy for us to do. In 60 seconds, we can know where your diet is now. In about 30 seconds, we can know what diet is ideal for you. And because we have 2 points, we can draw a line. We can literally subtract your current diet from your goal diet and produce a delta down to the nutrient level. And I'll explain how we do that in just a second. But more importantly, that journey from A, where you are, to B, where you want to go, is unique to you. It's truly personalized nutrition. And it's personalized nutrition predicated on 2 things that are not up for debate. What is the weight of scientific evidence regarding specific dietary patterns and specific health objectives? Managing blood pressure, managing diabetes, preventing diabetes, managing weight, reducing inflammation, etc. And what diet do you prefer? Because after all, the benefits of dietary pattern only accrue to people who are willing to adopt and maintain that dietary pattern. And that's largely been omitted from the dialogue. So what diet are you actually willing to buy into? And you could imagine that, how much better, for example, a diabetes prevention program would be if a Latin family could achieve the same high quality DPP diet, but it's Mexican. Or it's Indian for an Indian family, or on and on it goes, or you want to be vegan, or you want to try Mediterranean, or you're more interested in paleo, whatever it is, but same objective, high quality diet, but tailored to both your health goals and your personal and family preferences. So we do all of that. So we do onboarding, we do goal setting, and then we really complete the 4 key functions of a GPS. So this is basically GPS for diet change. Where am I now? What's my destination? How do I get there from here in a series of turns? So right, you get a turn list from GPS. Well, we have what we call micro challenges in our platform. So we do daily coaching to move you in that direction. And how's my progress? We do tracking, and we do tracking without requiring you to log foods or measure anything. We just update the assessment. Next slide, please, Jackie. And by the way, we didn't build in a demo, but if some of you want access to a demo after the call, happy to arrange that. You're also presumably all have access to this potentially through the Emerson relationship, which is really what we want to highlight here. But this whole assessment, is easily done. We're a web-based app. On a phone, on a laptop, on an iPad, any device that anybody has, internet enabled, anywhere, anytime, in about 60 seconds. So what we produce is a comprehensive assessment of where you are, what your goals are, the optimal diet that corresponds, and then we can generate a sequence of turns that will get you there from here. And this guidance is ideologically agnostic. I could tell you what diets I favor, but the simple fact is we wanted to include all diets that people actually eat and are interested in, and then we subjected them all to the same measure of overall diet quality, the HEI 2015, which has been validated against all-cause mortality, total chronic disease risk. So we can take someone who says, I want to eat low carb or keto, and direct them to the best version of that diet. And if they want to be vegan, we can do the same: Mediterranean, flexitarian, pescatarian, you name it. And just between us, those top tier diets are more alike than different. Pretty much they're all subject to the pollen clause. They're food, not too much, mostly plants. But they're different enough that they are true to type, and they give people lots of options. They offer up variations on the theme, and that's a unique element of our platform. And by the way, we designed this as a white labeled API, and those of you who are potentially involved in other efforts in the health promotion, dietary improvement space, effectively we can be the Intel chip inside. I don't know if that's still as good a thing as it used to be. It used to be a really good thing. Anyway, we're a really good chip. And so, somebody else is doing digital therapeutics or has a comprehensive lifestyle change program or is doing health coaching. Okay, well, then maybe all you need is the assessment, the goal setting, and the tracking, and you'll take care of the coaching. We're happy to plug in there. Next slide, please, Jackie. And this wasn't just me, sweating after that experience on the elliptical. One of the first things I did was turn to a bunch of friends and say, tell me what's wrong with this idea. It can't be this simple. And these are some of those friends who helped me out. Frank Hugh, who's now the chair of nutrition at Harvard, was also involved in the early going. We also had recourse to some experts in behavior change, BJ Fogg at Stanford, Jim Prochaska at the University of Rhode Island, who co-founded the Stages of Change and the Trans-Theoretical Model. But Christopher Gardner leads this group. Walter Willett, who was integrally involved in the last great advance in dietary assessment, the semi-quantitative FFQ. And I imagine you recognize some of these others. David Jenkins invented the glycemic index. Linda Snetzelaar is editor-in-chief of the Journal of the Academy of Nutrition and Dietetics. So fantastic group of people helping us get this right from the start. Next slide, please, Jackie. And there's a lot of science baked in here. And I think that's how a good app always works. Lots of hidden science back behind the curtain, really easy at the user interface. So I don't want to belabor this, but we were in basically research and development for better part of 5 years. We've been in the market for a little over a year. We have about 50 clients. We're widely deployed. We've reached tens of thousands of people, but it's a pretty truncated experience. We're new. But what we spent our time doing in the beginning was, after ascertaining the distribution of diets in the real world, we had a team of scientists providing high-level guidance, and then we had a team of dietitians. And the gist of this is as follows for those of you who care about the details. We started out with operational definitions for each type of diet, mutually exclusive of every other type of diet. We then established the ranges of HEI 2015 scores that would populate 10 tiers. We settled on 10 tiers empirically after trying 5, 15. It passed the Goldilocks test. We wound up with 10. Our dietitians then develop a full 3-day menu plan that is true to that type of diet and at that tier of quality. After they've assembled the dishes and the foods and the recipes, we analyze it. And if the HEI 2015 score isn't quite right, we make adjustments to that menu plan to get it right where it belongs. Once we have that 3-day meal plan fully developed, we convert it into an inventory of dishes and foods. And for that comprehensive inventory and dishes of foods, we resource high definition photographs, either that we have taken in a studio or that we secure online. We then turn over those that library of high definition photographs to our culinary cartography team, whose job it is to turn that into a comprehensive composite image representing that specific diet type at that specific tier of quality in an image that is arranged in the same way every time. We want the eye to do what the eye needs to do, but we want to minimize the burden on the eye. So you shouldn't be looking at, nothing else should be in motion, this diet versus that, but arranged comparably. We then realized, once we were pretty far into this, that 3 days worth of food is a lot for the eye to take in, and those images didn't really fit on a mobile screen. So what could we do? We invented a technique, and by the way, there are many layers of intellectual property here and patent filings pending and so forth, but we invented a technique we call dietary fingerprinting. So, this teeny little part of me will map to me and only me in all the world. It's just a bit of me, but it uniquely identifies me. We thought, well, we should be able to do that for diet too. So can we produce small vignette images that capture the singular foods that best represent that unique place in our map, that unique combination of X and Y, diet type, diet quality? And the answer was yes. So for every one of the diets in our map, we have this vignette. And 2 of those composite images fit on a mobile screen at the same time. So you can do the this versus that game. And then behind the scenes, we analyzed all of this using NDSR, for those of you who do nutrient analysis. So our dietitians use NDSR to do nutrient level assessment. So for every diet in our map, we have levels of more than 150 nutrients. And what we did was we stored them relative to calories. And then we used the Mifflin-St. Jeor equation. So we ask you age, sex, height, weight, activity level, so we can estimate your energy requirements. And that's how we right size the diet. So we get the type, we get the quality, but now how much of that do you eat? We determine that using the Mifflin-St. Jeor. We could interface with technology to get exercise inputs as well. But our standard default approach is the Mifflin-St. Jeor. And so we determine your approximate energy intake level, and then we dip into our database where we've got 150 nutrients or more per calories. We calculate your calories, and then what we report out to you, you being the health professional in an even more comprehensive dashboard, or you being the patient who's the end user, your diet type, your diet quality, and your intake level of up to 150 nutrients. We can also report out the distribution of different food groups. And when we get into dietary change, we're looking at change down to that level. Servings of this, servings of that, teaspoons or tablespoons of oil, levels of vitamins, minerals, antioxidants, etc. Next slide, please, Jackie, and I'll wrap up soon so we can get to Q&A. We have obviously committed to high levels of science and trust in the innovation, but verify with research. We have validated this initially against the FFQ and published one paper on that topic. An outside group did the same with the 24-hour recall. That's currently in press. We also routinely ask our users, did we get you? And we've had tens of thousands of users. So we have a completion rate of 96%, which is a standard. That just tells you how easy it is. I think the completion rate for FFQ is, it's probably 2%. I mean, most people give up. 96%. By the way, I did one appearance on the iShow during the pandemic talking about nutrients and immunity. And at the end, Mehmet asked me, well, tell our audience a little bit about DietID. And he told me in advance he was going to do that. So we arranged to make this available free in a limited manner to consumers at that time. And well, the result of that segment crashed our server. Ultimately, I think we had 16,000 people do the assessment. 96% of these daytime TV viewers, some of whom were over 90 years old, completed the assessment. Really quite a standard. So anybody can do this. And the accuracy rating we get is we have a visual analog scale to ask people, did we get you? How close is this? Consistently above 90%, which is also really great. We've had this used by people as young as 18 and as old as 100 just recently. And the average time to completion for ID plus ideal is less than 5 minutes. It actually should be done in less than 2, but again, some of the octogenarians are not all that tech savvy. Next slide, please. And again, we're widely deployed now. We have about 50 clients. We're especially proud of our partnership with Emerson. It's a strategic partnership arrangement. We really expect to do great things together. Delighted to have access to an audience such as this. But we're in a number of places, and more large health systems are adopting us, and great people like Dean Ornish have lovely things to say about us. We are a potentially great addition to cardiac rehab programs. Next slide, please, Jackie. And I think we're just about at the end of what I had to say. I think I am.
Wonderful.
Yeah, so it's over to you. So again, pleasure to be with you all. Jackie will take it from here, and then we'll do Q&A.
Wonderful. Well, thank you guys all so much for listening. And I'm sure you're walking away as blown away as I am at this tool. You do actually get access to DietID for free as a customer of Emerson Ecologics and Elevate. So within the Emerson website, this is myself logged in. You can visit this education section, and then there's resources that will kind of pop out in a drop down and lead you to this page. And you just click here where it says DietID. And it will drive you to the landing page that has all the instructions. We make it so easy. So essentially, you just send the link to your patient by email for them to complete the assessment. They enter your email, and it comes back. The assessment comes back to you via email and actually produces a result that shows their average food intake, like macronutrients and micronutrients, and also highlights likely deficiencies. So it's really easy for you to take action on that. If you're using the Diet Ideal tool, The DietID tool can coach the patient to that, but even without, you can get a very good snapshot of your patient's exact needs. Like Dr. Katz referred to at the beginning, with the ability to, like, supplements truly being a supplement to their life, you can see exactly what people would need. And then you can also send prompts to your patient to follow up. So we put everything in there. The resource center has even things down to sample emails to the patients. You can click the plus button, it will drop open, you just cut and paste into email and then send it out to the patients that you want to complete the assessment. Or we've also created one if you wanted to put it into like an e-newsletter and send it to all of your patients, and then maybe think about charging for that nutrition review. It's an extra opportunity for a visit to review their nutrition in depth and think about what types of modifications they can make. So lots of great ideas there for you from a practice management perspective as well. And just finally, we're like so proud for Emerson and Wellevate to be in partnership with AIHM. I'm particularly inspired by AIHM, coming from naturopathic medicine and naturopathic leadership. Really the whole mission of the organization to bring like-minded professionals together. And I would say, like, scrub the letters after our names and put us in here really as colleagues that are working together towards a common mission. It is exactly what we believe in. For me personally, for us at Emerson, I'm really wanting to do what we can to help make practice easier so that all integrative practitioners can reach more patients, which is really what we need. Just to talk a little bit briefly about Emerson and Wellevate themselves, if you're not currently a customer, we offer both a virtual and in-office dispensary. We have about 375 brands of products, probably all of the professional brands that you utilize that you can get in one place. And we really offer two solutions for balancing your dispensary. You can have an in-office dispensary, and our Emerson website would service that. So you can buy the products at wholesale to stock in your office and then sell to patients. Or we also have an online dispensary tool called Wellevate. And really the whole point is to help you retain and grow your business and to help improve patient care and make it easier for patients to get access to the things that they need to be well. So in-office dispensing with Emerson, you get wholesale pricing just like you would if you went direct to a company. You only have to order from one place rather than ordering from multiple places. And you can offer whatever products you like for your patients that like to shop in person, and know that you have the quality of, or you have the trust with Emerson, with us validating the quality of the products that we sell. When you purchase from Emerson directly, you also get free shipping for orders that are $250 and above. If you don't want to stock in your own office, we also have Wellevate, which is a virtual dispensing tool. We can certainly talk more about this at another time, but it's really easy for you to get started. Your patients get 10% off when you get signed up. And essentially, this allows you to build a dispensary online. You can do things like send custom recommendations to patients so they know exactly what product they should buy and what dose they should be on. Or you can operate it a little bit more like an online store or online dispensary, where you tell the patients what to take in whatever form you're currently using through your EMR on a piece of paper. And then your patients just visit your Wellevate site to get access to those products. We have things like auto refill for patients to make it really easy for them to stay compliant, and free shipping for over $49. We also have an app, which is awesome for patients. And I'm so excited about our plans for the app this year to really expand that and make it an even better tool to keep your patients engaged with your practice, not just when they're there, but then in between visits as well. And then finally, last December, we launched our newest free tool within the suite that we offer at Emerson and Wellevate, which is telehealth. So we partnered with VC, one of the top HIPAA compliant telemedicine platforms, and we now offer free telehealth visits. So with the pandemic, I know most of us have had to go online. And if you're like me, at first you might have been using FaceTime or Skype or whatever was available to you and to your patients, because getting a HIPAA compliant telemedicine platform can cost money. Well, we've partnered and we pay the cost of it to make it completely free to you. So that does scheduling and houses the visits all within Wellevate. Super easy, one-click video conference. And like I said, completely HIPAA compliant. So you don't have to worry about using a platform that might be putting you at risk in the future. If you're interested in learning more or signing up for an account with Emerson or Wellevate in order to get access to DietID as well, you can visit the AIHM page which is at go.emersonecologics.com/AIHM. And when you go to sign up, you can also use this coupon code with your first order, like I said, to get 10% off. So I hope you'll check it out. It's a great way to get access to the DietID tool for free, which I've been using with my patients, David, and it's been like pretty amazing. And they love how easy it is. And they get such concrete information back that I think it's pretty cool. I mean, it's so much better than the recall, where I had to look at the recall too to try to guesstimate where they were at. This is so quantitative and it's really easy for me to take action on. And my patients also love to see, and it improves their compliance when they know, okay, my magnesium really is low, so I do need to focus on these foods that Dr. Chasse-Smeaton's given to me, or I really do need to take that supplement to make sure I'm bridging that gap. It's so visual and so easy for them to see. So thank you guys so much. And we are very happy to take any questions you might have.
That's wonderful feedback, Jackie. Thank you. And I've been scanning the Q&A while you were talking, and I can just, and folks can chime in with additional questions, but Lena asked about nutrigenomics and if I'm recommending against it. No, I'm not recommending against it. It's just not fully ready for prime time. The best current study on nutrigenomics was Diet Fits, Christopher Gardner and colleagues at Stanford, 2018 in JAMA. They actually measured all the relevant SNPs we know about that theoretically should predict responses to specific dietary patterns. And again, I'm not talking about methylated folate or nutrient-specific decision-making. I'm talking about dietary pattern adjustments based on genomics. And they had SNPs that should have predicted favorable response to low fat and SNPs that should have predicted favorable response to low carb. They randomly assigned people to one or the other. And the genetic predictors predicted absolutely nothing. So again, the study is Diet Fits, Diet F-I-T-S. It's the latest best word. I do think ultimately we'll have enough information on genomics for it to be predictive. I also think if we combine genomics with other omics and other biomarkers, ultimately we can customize what we know about the general benefits of diet, and we're more likely to get it right for an individual. But again, why overlook what's in plain sight, which is people like to eat a particular way, that they may have a style, an ethnicity, a cultural approach to diet, and most people have specific health objectives related to diet. Well, there's a massive of scientific evidence in the peer-reviewed literature linking specific dietary patterns to specific health benefits. And if you can combine that with, okay, here are a bunch of options, which of these is comfortable for you, it's more fully mature than nutrigenomics. We can combine the two ultimately. So if nutrigenomics matures, we can do a nutrigenomic assessment and say, well, your preference does or doesn't align with what your genes suggest is likely to work best for you. We're happy to integrate. So remember, the whole approach to DietID is a string the pearls approach, and we know there are other pearls out there. The reference for, so Lena, thank you. Fernanda asked about the reference for dietary patterns, the coffee table book, that's Hungry Planet, What the World Eats. Where do you find DietID? Well, in this context, as Jackie mentioned, you can find it through AIHM, you can find it through Emerson. You're right, we have not been in the App Store to date because we are a B2B company and we're interested in integrating with our partners. But in fact, we are adding this to the App Store, not for individual end users to use, but we're just making it available both in iOS and Android. So within about a week, we'll be available there. There are a number of questions about dietary restrictions, sensitivities, allergies. Yes, we address those. We comprehensively assess for dietary assessments. Now I've got all sorts of stuff going on in the background behind me. And we can adjust the dietary guidance for that. However, really important, I think, Jackie, Tabby, I don't think even the very best coaching app can replace the human touch. And I know that many of you do elimination diets. You're expert in that area. So we can give you the information you didn't have before about comprehensive assessment of the baseline diet. And we can provide vivid clarity about a goal diet. But then if you're superimposing on that some specific set of restrictions, patient's still going to need your help. We, by the way, provide meal plans. And so we really can get people launched. And those meal plans also can be adjusted for dietary restrictions. our navigation platform is adjusted for dietary restrictions. So that turn list I described, which is a sequence of micro challenges related to dietary change, adjusted for dietary restrictions.
Dave, I just
And
wanted to say, I mean, I just love how this brings us into like 21st century. Honestly, it's like the secret being out about how difficult the diet diary, to really implement that for people. This is just so amazing. I'm so thrilled about this, and just think it's going to be just an amazing tool for, both that clinician patient partnership. So bravo. I mean, all the work is just phenomenal, and I'm really looking forward to using this.
thank you. That's very exciting. Sorry.
It's okay. We all have kids at home, so
Yeah.
take a moment if you need to. It's totally fine. We've got
Thank
some
you.
more questions too coming in
Yeah,
the
so
Q&A.
So I
okay, yeah.
think a couple questions around kind of the logistics. So if you want to try DietID, you absolutely can do it yourself. So you'll see if you visit the Emerson or Relevate pages I talked about, there's a web address that you would send to a patient, and all you have to do is click on that link yourself and complete the DietID. It's nice. You can do it a couple of times, see what it would be like for your patients, and try it out with what different types of diets you think your patients might be eating compared to your own. And you'll very quickly see how adaptable the tool is to really meet like anything from a standard American diet to Dr. Katz's diet, probably on the two ends of the spectrum. So definitely we encourage you to give it a try. A couple of quick questions around Wellevate and Emerson. So someone asked, Deborah asked, is Wellevate a wholesale price? Wellevate is actually intended to serve your patients. So you have the opportunity to earn money within Wellevate or not, whatever you prefer. But you have up to 35% to play with. And when you set up your account, you have this sliding bar that's very easy that will allow you to choose what percentage of that 35 you want to offer to your patients the discount and what percent you want to keep as a profit. So for my own practice, I do a 25% discount for my patients, and I keep 10% of the sale as a profit. Most practitioners do between 5 and 25% generally. And that incents your patients to go to Wellevate because it's such a beneficial piece to get a discount. And it makes sure that they're not going to be finding cheaper product on Amazon or something like that that may not be as good of a quality. So
can you speak to just for a minute, Jaclyn, about also just the tools in Wellevate, like the customizing of plans and really just get how you can pass that on to patients. It's really the way that it can be personalized is such a great tool for busy clinicians.
Yeah, I mean, for me,
Jackie, before you do, just quickly, because we'll run out of time, I'm seeing lots of questions that I'm not going to have time to answer. DietID.com, and you can follow up with me or my team. Will be happy to take the particulars there. To the extent that they're not answered here, I'm happy to follow up. Sorry, Jackie.
Thank you. No, that's okay. So within Wellevate, I mean, there's so many amazing tools that it really is very time saving. I don't get calls with questions anymore. So we have the main function in Wellevate that I recommend is using the recommendations feature. And that's where you build a protocol for a patient and you send it to them directly. So all you need is your patient's name and email address, and you can put in the name of the protocol. You have an open text field that you can put in a note. You can attach any handouts. So if you have a meal plan for them or exercise instructions or meditation instructions, you can upload those as well. And then you add the specific supplements with dosages that you want. And that gets stored in the patient's profile. So when they log in through the app or through their computer, they can view what you recommend today, but also everything you've ever recommended. So if they, last year when you saw them for when they had a cold, you put them on an immune support product that worked great for them, they can take a look at what that was rather than calling your office to ask that question. We also have a protocols feature, which I recommend using. I work in the world of fertility, so I have a lot of protocols that I'm using over and over again within a specialized field, and I've saved them all as protocols. So now when I want to write a sperm motility protocol for a patient, I click a button and it pre-populates everything that I usually use. And then I can just make a couple quick edits from there. If I think that patient has a special need that I should remove this product or add this one instead, but everything is there to start with. So it literally takes me 20 seconds to send a full protocol, including all the handouts I want them to know about lifestyle, all the products I recommend. It's very, very quick. And we also launched a feature where you can send a protocol blast to all of the patients in Wellevate, which we did because a lot of doctors were saying, people are calling me wondering what they should have for immune support. How can I do this? And so we quickly launched a beta that's now available where you could create a protocol or a recommendation, maybe called immune support. And rather than send it to just one person, you can send it to everyone with a message like, I'm getting a lot of questions about what you should be armed with. Make sure you have this vitamin D and this zinc. And I recommend this immune support product just for enhanced health and wellness. So we give you the option to almost use it like a marketing tool really for your practice and to answer patient questions. So lots of little nuances in there and little tricks and tips, but we have got a great team of concierges inside. So if you call our customer support team, they'll very happily guide you through what's best for your practice.
And now with this DietID, it just feels like, it's really going to round that out and be able to provide something that's really not available out there right now. So David, I don't know if you have a few more minutes, if you wanted to answer any of the questions or just say some final words. I know you have to go.
Well, yeah, I think probably the best way, there's an array of questions. Cost usually to the patient is nil because, again, we're a B2B. So usually the end user is not paying. We fold this into a practice. Obviously, this is folded into the Emerson platform. And if you're using Wellevate, the DietID is just included for you. So it doesn't cost you and it doesn't cost the patient. So that's our intent. Ultimately, we didn't put this in the App Store and try to sell it to the end user. We work through practices. You don't separately charge patients for use of a blood pressure cuff. We shouldn't separately charge patients to have their diet assessed so we know what to recommend. Many questions about, subtleties and nuance. And again, we really think this is a complementary tool. A blood pressure cuff does not relieve you of the obligation to address blood pressure as you see fit. Pharmacotherapy, lifestyle change, combination of the two, managing to goal, that's all on you. So, again, we can do an awful lot, but minimally we provide that comprehensive assessment and can do it in about 60 seconds. So you're empowered to do what you've been inclined to do all along. We're not taking any of that away. Yes, we have validated this. I mentioned that. And again, if you go to the DietID website, you'll see access to our published papers. There are more of those in the works. We have some preliminary efforts against biomarkers where we're performing well. But the validation effort will go on for many years. We'll do lots of studies, ultimately including outcome studies. So, many good questions. And again, to the extent that I haven't gotten to them, visit our website. There's a lot of information there. And there's also a contact link there. If you still have additional questions, we're happy to answer. But I think I want to wrap up, Tabby, just by saying it's been a great pleasure and a real privilege to access this audience. So my thanks to you, Jackie. And once again, we're really proud of this partnership because, I think working with Wellevate, there's so much we can do together. We can empower patients to know more about their diet. We can empower patients to be in a better position to improve their diet. We can service this wonderful clinical community so you have information you didn't have access to before. But none of this takes away, the art and science of what you all were already doing. We just, again, a blood pressure cup helps you manage blood pressure. We think we've got a role to play in helping you manage diet better.
Well said. Thank you again so much to both of you. Just really appreciate, the time and being able to bring this to our community. So just to wrap up, I would love to invite you all. We're very excited next week for our wellness webinar next Friday, February 26th. We will be hosting a talk on integrative medicine in medical education, culture, and society with Dr. Rashmi Muller, MD, Salani Gupta, and Tanya Datta. And they are from UCLA, and we're just so excited to have them on the program. The two young women, Salani Gupta and Tanya Datta, were actually our student research winners this last October at the AIHM annual conference. So they're just doing some tremendous work and we're going to get to hear from them next Friday. So please join us then. I also want to invite you all to a really incredible event that we've just put together. The AIHM board really wants to provide low-cost education to the community right now, especially around the challenges that we're all facing with COVID. So we'll be hosting a 4-day online virtual event called Hope, Resilience, and Healing in the COVID-19 Era, Practical Tools for Integrative Clinicians, What We Have Learned in the Last Year. This will be running from March 24th to the 27th, just around the corner. The event will have approximately 15 CME for those of you who need your CME hours. And for members, the cost is $50 and students $25. So we have about 30 speakers for the event. It's going to be really incredible. And we'll be hosting some Indigenous healers and leaders who will be sharing as well some of the activist work that they've been doing around COVID in their communities. So I really encourage you all to take a look. You can go to aihm.org/conference and sign up for the event. And then just continue to connect with us. Our YouTube channel, youtube.com/AIHM Global, or find us on any of the social media platforms. Please consider joining the AIHM member community, and we will see you all next week. Thanks again to Emerson and Wellevate for their sponsorship of this event and of the Academy in many ways, to Dr. Jaclyn Smeaton and Dr. David Katz for joining us today and for the incredible work that they've done on DietID.